such as, your practice size, whether or not you're a specialty practice, the location, and also your patient population. And so that's something to keep in mind. But as you can see here, there's several ways that you can pick whether or not how you want to report. And of course, the first one being not participating. For those that decide that they don't want to participate, there will be an automatic negative 4% payment adjustment for 2019. However, CMS is providing eligible clinicians the opportunity to report some data. They're using this 2017 reporting year as a transition year where not only is CMS learning, but also allow eligible clinicians to the opportunity to learn and get used to how this is all going to come to play. And as you can see, you can submit some data. So basically, some data would be at least one measure in any of the categories with a minimum of 90 days of data, which will give you a neutral or small payment adjustment. You could also submit partial data, and what that means is reporting more than one measure with more than 90 days but less than 1 full year's worth of data. And partial year would provide you a small positive payment adjustment, likelihood of a little bit more of an incentive. And of course, there's always that submitting the full year. So if you report the full year based on each category's max of measures and improvement activities, you'll probably have a higher likelihood of getting a modest positive payment adjustment. And of course, there's also if you are a participant in an advanced APM, which, as I mentioned, Jackie will be covering. But you will notice here that the data collection should be between January 2nd and October 2nd of 2017, which October 2nd, one thing to take away is that that's basically the last day that gives you continuous 90-day period of time that's required to reporting to begin. So it allows you that 90-day cushion to be able to report. So that's why there's that October 2nd. But one thing to keep in mind before I move on is that the positive adjustments based on reporting are based on the performance data of the information submitted, not on the amount of information or the length of time submitted. So it's possible that if you do submit partial years, that it's likely that you might be able to select a measure that will give you the opportunity to increase your chances of getting a little bit more of an incentive. It's all based on the measure or measures you select based on those categories. So just keep that in mind. Here I wanted to just kind of briefly talk about who's eligible clinician. Most of you already know that years 1 and 2, as you can see here, there's physicians, physician assistants, and so on and so forth. And you can kind of read who will be eligible in terms of reporting this year. But one thing that I kind of wanted to take a little bit of time to mention is this patient-facing versus non-patient-facing. I know that many, especially physicians that are, say, for instance, an example would be like an anesthesiologist or pathologist. You know, one thing that CMS did mention is that although you know, non-patient-facing physicians are not necessarily exempt and they don't necessarily see actual patients, instead of actually giving a list of providers that will meet that non-patient-facing definition, they decided to go ahead and kind of open it up to these two criteria. And I will caveat that CMS still plans to finalize what those patient-facing encounters will be and non-patient-facing. But for now, you can see here on the right hand under non-patient-facing, if you're an eligible clinician that's billed 100 or fewer patient-facing encounters during a performance period, there's likelihood that you might be considered non-patient-facing. And also for groups that are providing more than 75% of their MPIs billing under a TIN, and they also meet that non-patient-facing definition, they will be grouped into this non-patient-facing. And the reason why this non-patient-facing, you will actually be grouped under the small practices and those rural practices in terms of the improvement activities category specifically. And so you kind of have some sort of smaller number of reporting that comes into play. So it's I kind of wanted to mention that I have more notes, and please feel free to ask me questions on this. I have plenty of information, but I just kind of wanted to mention that as we're going through, because I know not many folks have concentrated on that. So just thought I'd provide that. And basically, who's exempt? For 2017, the exemptions, as you can see, are if you're a newly enrolled Medicare clinician, basically a clinician who's enrolled in Medicare for the first time during the performance period, you're exempt. Also, if you meet a low volume threshold, which basically means that you billed less than or equal to $30,000 of Medicare Part B fee-for-service, or you have seen 100 or fewer Medicare patients within a year, you're also can meet that exemption criteria. And also, as you can see, participants under the advanced APM. Now, I will say now, to make it easier for eligible clinicians to know whether or not they're exempt, CMS does plan to run an MPI and TIN analysis on all Medicare Part B eligible clinicians to see who meets that low volume threshold. And basically, there's kind of a logic that they're going to be taking claims data and whatnot. But really, a takeaway is that you'll have the ability near the end of this year to go onto the QPP website to search to see if you are exempt for 2019. I will say that CMS does plan to conduct 2 assessments to evaluate if you're exempt. So it's possible that a clinician might not be initially exempt, but a few months later, under the second go-around that CMS plans to do, you might meet that threshold of the exemption. Again, this is under the low volume threshold. And of course, I did mention to kind of encourage folks to get on board in terms of advanced payment models. For those that are under the advanced APM, CMS is piloting a program to reduce medical record review, which is always a positive because I know folks don't like being audited, so if you can minimize that, that's always a positive. Now I'm just going to dig into the MIPS portion of it. As you can see, there's 4 categories. There's the cost, improvement activities, advanced care information, and quality. As you can see, cost is 0%. It used to be 10% under the proposed rules. That 10% was shifted to the quality side of it, so the quality piece of reporting went up by 10%. The improvement activities, which is the new category, and the advanced care information, which replaces meaningful use, that stayed the same. Here you can see the MIPS performance category weights for 2019 up to 2021 and beyond. I won't concentrate too much on that. But in terms of the transition year, one thing I kind of wanted to mention here is that so it's possible that there might be some eligible clinicians that might not have sufficient measures applicable and really available for each of the performance categories. So, so in order to give eligible clinicians an appropriate scoring, this is kind of a re-weighted scenarios, particularly for the advanced care information and quality categories. And I'll give you just a quick example. So let's say, take for instance, you're a small practice, and the advancing care information, which is what meaningful use is being replaced by, is re-weighted because, say, you either apply for a hardship exemption or you have limited use of EHR, for instance. So as you can see, that 0%, that weighted category was shifted up to the quality category, and of course there's the quality performance one as well. But I won't. You can look through that information at a later time. Here I kind of wanted to just briefly talk about how MIPS category changes were impacted here based on the proposed rule. The cost category, what's happening here is that 2017 CMS does not plan to score it, but they will provide practices and eligible clinicians feedback on that. However, in 2018, they do plan for it to to have a 10%. It'll comprise 10% of your scoring. On improvement activities, you have the ability to either report one activity because it is pick your pace and it's very flexible, or you can report up to 4 categories if you're interested in full year reporting. Basically, 2017 and 2018 you have will be 15%. Activities can be implemented at least 90 days, so at least 90 days worth of data. The activities span about 94 activities over 8 categories that are listed in the final rule. And of course, 40 points or 20 points will depend on how MIPS clinicians decide for reporting activities. So depending on whether or not you're a group of 16 or higher, you'll have to report so many activities versus if you're smaller. So, and I'll dig into those here in another slide. And then of course there's the advancing care information. Really the takeaway for this one, again, you can decide to either report something or report the 4 measures for 2017. And then for performance score, you can report up to 9 measures. For 2017 and 2018, there's that 90-day reporting, and really the reason for 2017 and 2018 being a 90-day reporting, which is what at minimum they're requiring folks, is because, again, they're trying to move towards the usage of electronic, the electronic use of records and whatnot, and so they're allowing folks to kind of just slowly transition into that. And again, another change from the proposed rule under the advanced care information is before it was 100 points, but it actually increased now to a possible of 155, although only 100 are required to get that max scoring here. And of course, there's that 10% bonus for reporting improvement activities using CERT. So again, CMS is trying to encourage folks to use more of the electronic records for reporting. And the last piece that most people are probably most familiar with is the quality category. One of the biggest changes for this one is that, unlike before, the proposed rule, I believe it was between 80 to 90% of your patient population, which includes not only Medicare but all payer patients, they actually decreased that to 50%. And of course, you can see that for 2018, that'll increase to 60%. Here, I kind of just wanted to walk folks through this. Here's the MIPS measure reporting by category. The only major difference, as you can see, both groups and small practices, rural practices, and also so the HPSA is basically those practices that are located in geographic health professional shortage areas. And again, I mentioned previously, non-patient facing, you'll be under this category. Everything basically stays the same other than improvement activities. For if you're on the under the small practice grouping, for instance, you can report on either 1 high-weighted activity or 2 medium-weighted activities, versus if you are in a group of 16 or more eligible clinicians, as you can see, you can report 2 high-weighted activities or 4 medium-weighted activities, or you can kind of mix and match to kind of get that max point scoring. And it's the same here, nothing changed from the proposed rule. If you are a certified patient-centered medical home, you will receive a full credit under this improvement activities category. Under the advanced care information, again, here you're required to report up to 4 measures. 4 measures are required, but again, if you want to at least report one measure to kind of alleviate you having to get that negative fee adjustment, you can report 1, but your 4 required measures for the base score and up to 9 measures for the performance score. And again, as mentioned before, there's that bonus piece if you are using CERT to report improvement activities and reporting to public health and or clinical data registries. And I will mention, because advanced care information, which again replaces meaningful use, there might be a situation where you might want to apply for hardship exemption, and I would encourage you to visit the PP website, the Quality Payment Program, CMS's Quality Payment Program website for more information on that. And here, this is the data submission. different ways to report your data. And really, key takeaway for this one is that if you're an eligible clinician or a group, you may elect to submit information multiple ways. Really, a takeaway here is that you must use the same identifier for all performance categories. And so really what this means is that you can only use one submission mechanism per performance. So for example, if you are an eligible clinician, you can use one submission mechanism for sending quality measures and another for sending improvement activities. However, you cannot use two different submission methods for a single performance category. So say, you can't say submit 3 quality measures via claim and then 3 quality measures via registry. So if you're going to report under one category, you need to do one, or you can just choose to report it all in one single thing. But I will say, up to this point, we've talked about the flexibility reporting for 2017 reporting year. However, for those that do plan to submit, there's that caveat, plan to submit via CMS web interface or CAHPS MIPS survey, full year reporting is required. And really the reason for this is because the submission mechanism utilizes certain assignment reporting and sampling methodologies that are basically based on 12-month period. And so I will say that, and I know that a lot of MSSP ACOs that have been reporting using CMS web interface, they will continue doing that, and you are required for full year reporting. And so you're probably most familiar with how to do that. If you are going to report through CMS web interface reporting, you must register by June 30th of 2017 if you plan to use that mechanism for submitting. I'm not going to dwell too much on this quality performance category, but basically you can read through that. Everybody will be getting the presentation. But if you're interested, there might be a situation where you want to report a quality performance category, but for some reason you do not have enough cases to reach, and it kind of tells you how your points will be distributed and the scoring rules for that. So I kind of wanted to take a little bit more time on this MIPS payment adjustment, which is what's most unique and a big change from previously proposed rule. Really a key takeaway for this 2017 performance year is that the performance threshold has been set to 3 points, as you can see here by that little red arrow there. And for those who achieve a final score of 70 or higher will be eligible for that exceptional performance adjustment funded from that pool of $500 million that is in the actual mandate. So CMS basically says for that 70-point pool, they say that it's appropriate because it requires MIPS eligible clinicians to submit data for and perform well on more than one category, performance category. So all in all, the final MIPS payment adjustment will be determined by the distribution of the final scores across MIPS eligible clinicians and the performance threshold. So as you can see, if you report at least one measure, you should be fine. And again, keeping in mind that it has to be a 90 continuous days. So if you decide that you want to report on several different measures on different categories, you don't have to take the same segment, 90-day segment. You can decide to report 90-day segment in the middle of 2017 calendar year and then pick something near the end. So again, it's all about learning this 2017 transition year. And I think the best way to understand how this MIPS payment adjustment is going to work for 2017, I thought I'd give you a quick example that was written in the, that was provided by CMS and the final rule. So let's take this example. Say you are a MIPS eligible clinician in a group of, say, 20 MIPS eligible clinicians, right? And so you decide to report as a group. And as a result of submitting, you only decide to submit data for improvement activities under that particular category, right? So as you can see, I break it down because although there is 4 categories, we know the cost category will not be weighted this 2017. So let's take those 3 categories. As you can see here, you have the quality, the improvement activity, and the advanced care information. And so as you can see, let's take this quality category. So as you can see, even though that this group did not submit quality measures, to the quality performance category, the group is still measured on the readmission measure because the group has submitted improvement activities as a group. Now, for readmission measures to apply, a group has to meet that case volume, which is 200 cases, and you can kind of read on the very bottom that yellow box there. So because of that, they applied, for this example, they applied that measure, that readmission measure, which CMS is the one that ran that information, and they found out that they were poor. They had a poor performance on this readmission measure, but at the very end, they still received that 3 points for that readmission measure because some data was still collected, and so as a result, you see that 3 points. Now, in this scenario, you can see that they reported they performed only one high activity for the improvement activities, and the scoring for groups of more than 15 clinicians, all groups who perform one medium activity will receive 10 out of 40 points under the improvement activity score, and those who perform each high activity receive 20 points. And as you can see, they did have one high priority, so they got their 20 points there. And of course, you have the advanced care information they decided not to report, so there's 0. So as you can see there, this is kind of how the math is all calculated. And at the very end, they get 10.1 points. So their likelihood of being able to get a higher score or higher percentage of an incentive is a lot better, even though they only reported. So again, going back to what I previously said, although you only report on one measure, you can still score higher than 3 points within that threshold that CMS has and still be able to get a slightly higher incentive than previously anticipated. So at this point, I would like to go ahead and pass the baton to Jackie.
Great. Thank you, Maria. Good afternoon, everyone. It's nice to be here. So now we're going to talk about the second component of MACRA, which is, of course, is the alternative payment model component of this. So Maria focused on the MIPS section. So we have 2 components of MACRA. You can report in through the MIPS, or you can be reporting in through the APM. Now, they have made some changes to the APM model as compared to what was put out on the proposed reg, and we're going to spend a few minutes talking about that. So let's go to the next slide. What is an alternative payment model? So it very clearly, CMS has defined it as an approach for paying for care. It's a payment model, and of course it has to incentivize both quality and value. So, and any of these programs have to be approved through the CMMI, so the Innovation Center, and it also has to be either through the defined by the Affordable Care Act, or an MSSP, or a statutorily required demonstration project, because there are demonstration projects out there that are required for regional areas to participate in. So that's important to remember, that that these APMs actually sit by their own rules. They come out through the rulemaking process, and they continue to always be primarily supported by their rulemaking process. And that's important that people understand that MACRA is not changing how those APMs function. So next slide. So I think what's can be very confusing about this component of the regulation is that CMS is really trying to be flexible for providers. They know they have folks out there participating specifically in MSSP Track 1, which has not been per se an advanced APM model. So we will talk a little bit more about that. So right now they differentiate between an alternate payment model and then the advanced alternate payment model. So an alternate payment model is an approach that, of course, incentivizes to provide high quality, cost-efficient, effective care. It's definitely put to usually a specific clinical condition, a care episode, or a population. And of course, it's opportunities for eligible clinicians to take on additional risk when they are involved in an advanced APM. So what is an advanced APM? So the advanced APM component clinicians will potentially earn greater rewards for taking more risks. Advanced APMs put the clinician at more financial risk on the upside or the downside alternative payment model. So this program, again, like I said, doesn't change it, won't change the design of the advanced APM, but it does create extra incentives for those participants. Next slide. So I think an important part of this is to recognize that MIPS APMs and advanced APMs are actually a subcategory of all the APMs. So again, MIPS APMs are reduced eligible clinician reporting. It's really about decreasing burden. CMS has heard for many, many years, especially since PQRS, meaningful use, and now the value modifier have been out there, that there is so much burden on our physicians and our healthcare organizations to report. So they really have taken a lot of that into consideration as they've developed this regulation. So it's really about keeping the focus on the APMs and then providing that additional incentive. So we're going to be seeing a lot of streamlining on the reporting and how do they use that reporting to support the macro legislation and have physicians successfully report in. So let's go to the next slide. So these are the MIPS APMs, and you can see they really have stayed true to the proposed reg. We have the ESRD care, we have the CPC Plus, we have the Next Gen, we have the Shared Savings 1, 2, 3, and oncology. And of course, Medicare Shared Savings 2 and 3 are only in the advanced APMs. Now, of course, a big discussion. We'll go to the next slide. Thanks, Maria. As you can see, the advanced APMs, again, include the oncology model and the Next Gen. Now, CMS is going to be opening up. A big concern when the reg came out, of course, was only 1 or 2 of these advanced APMs were still open for folks to sign up for 2017. So CMS has agreed to have CPC Plus and Next Gen actually come out this year for participation in, or they'll put out another release for groups to participate in 2018. So there is more opportunity for folks to jump into some of these advanced payment models, which is really important because that is the ultimate goal for CMS. They want to move folks, physicians and healthcare organizations into these payment models that pay for value. So there is a lot of penalty for folks who stay and really kind of just dig into the MIPS and just pay for reporting, pay for performance. So very important. Another big contentive issue was things such as bundles, Track 1, MSSP Track 1, CJR, the Advancing Care Coordination. Some of those payment models were not included in advanced APMs. And again, that was because of the downside risk. So CMS is definitely taking a look at that, and is they will be part of the advanced APMs in 2018. So I think what's really important is for organizations to think about their macro roadmap in light of MIPS and APMs and understand where they want to go. Just because, as Maria talked about, the pick your pace mentality does not give you a get out of jail free card in 2017. Organizations are still going to have to really closely look at this regulation, understand their roadmap and where they are and where they sit in their market and where their journey will take them in transformation to understand where they're going to fall in this driving into these advanced payment models. Next slide, Maria. So let's talk about rewarding. So I think Maria did a nice job talking about some of the scoring for MIPS and some of the payment incentive related to that. So when you talk about the advanced APM component, if you're not in an APM, you only are doing the MIPS adjustment. And again, she showed that you have a potential of earning a +3 payment incentive. Also, you could have a negative payment adjustment. if you don't report. Now, the monies are not as big as they had expected. That bucket of money will actually be not as significant as originally described in the proposed reg. So if you're in an APM, if you're in MSSP Track 1, it qualifies you now to submit your regular ACO reporting, and it will account for your MIPS adjustment. So that's a positive. So if you're in MSSP Track 1, you can still submit. You're submitting all your ACO metrics, and that will count for your MIPS. And then you continue to still get your APM-specific awards. So you still get your shared savings if you're still jumping through all those hoops, if you're performing well on your ACO metrics, meeting your targets, and also bringing down your costs, you will share in those savings. So then in the advanced APM model, if you are, again, if you turn out to be a qualified participant, a QP, and of course, you know CMS loves their acronyms, so lots of acronyms in this regulation. You get your APM-specific rewards, so you share in your savings, your upside risk as long as you're performing well, but you also get a 5% lump sum bonus. So that's important to remember when you take a look at these components in these programs and understand for your organization and for the physicians that are reporting what that means to you. So next slide, please. So what are the requirements for being an advanced APM? Okay, so CMS really clearly lays this out. You have to be using a certified EHR technology. 50% of your clinicians must be in a certified electronic health record. And you also need to be reporting at the TIN level. So remember, everything in the advanced APMs and the APMs is at the TIN level, the tax ID /NPI. So NPIs that are associated to that tax ID, everything comes off of that group TIN. The other second piece of this is provide payment for covered professionals based on the quality measures. So you have to be reporting your quality measures that are evidence-based, reliable, and valid. And one of those measures must be an outcome measure, just as it is in MIPS. So the CMS, again, is very committed to getting to outcomes, and they want to move away from these process measures. So very important for organizations and physicians and clinically integrated networks to continue to focus on measuring outcomes and understanding how they're performing in those metrics. And then there's a third step to this, which is if you're in a medical home, it needs to be the expanded medical home model from the Innovation Center under the authority of the Innovation Center, or that the APM is bearing more than nominal financial risk for monetary loss. And that's a key piece to this, again, that these groups are putting themselves at risk to lose money in these programs. Next slide. So let's talk about what does it take to become a QP. So first step is that they look at the group level. So the APM entity that is reporting, and they look at everyone together in that group. So that's important at the TIN level. The second piece to this is they create a threshold score. Now, for those of us who've been around CMS for a long time, know CMS loves to create their scoring methodologies. So they've created two methods that will assess an advanced APM. So they'll look at a payment amount method and they'll look at a patient count method. They will look at both of those scores, and whichever score trumps, will be used to be whichever score is more favorable in that calculation. They'll use to then say, okay, where are you on the continuum of that scoring? So next slide. So the next slide is the threshold scores that CMS set. So if you're, at a 25% of payment through your advanced APMs, you've hit the target. You've got a thumbs up from CMS, and you will be in that advanced APM. If your percentage of patients that are through the APM, again, through that patient count methodology, is at 20%, thumbs up, that's what they're going to use. And you can see it gets more aggressive as time goes on, so it's important to understand that. Now, CMS will give all advanced APMs a summary of this in early, I believe, 2017 for them to know where they sit. So it's very important for those to understand that. So, and then this is also important to remember, this is over a payment year. So it will be for the full payment year because these programs run calendar years. Next slide. So again, the performance period that physicians in an advanced APM will be evaluated on is actually, well, I said it was a calendar year, but they will be looking at a full calendar year. It's January 1st to August 31st for the calendar year. That is, remember, CMS always has a 2-year look-back period. All their programs run on a 2-year look-back. So if you've been doing these programs for a long time, you know it's on a 2-year look-back. So they're going to look at January 1st to August 31st. They'll have this performance period, you know, how CMS works, and then they have a year in between, which is actually where they're busy calculating out what your incentive payment will be based on your performance, so how much they're going to pay you. They're going to add up all your payments. They're going to look at your total number of dollars, and then you're in 2019, which of course is our first year of payment reform on this program. You will have a payment adjustment. Either you'll have a payment adjustment based on how your advanced APM performs, plus you'll also have a plus 5% lump sum payment. So how is CMS going to decide whether or not you're in or out of that advanced APM? So they're going to take a snapshot 3 times, March 31st, June 30th, and August 31st. They're going to determine if you're eligible clinicians. So clinicians who are leaving and are moving, if they're in on the first one, then they're good. So you will have movement between groups in these years, and it'll be interesting to see. I don't know off the top of my head how that will happen, but I think organizations will be responsible for understanding who's in and who's out of their groups. And when they move to a new group, that new group will not actually benefit from that physician's billing, even because they would be attributed to a previous advanced APM, I believe. So we'll have to get that a little bit more clarified. Next slide. We're almost here at the end. So, you know, CMS is really recognizing the importance of moving everyone into these advanced payment models and paying for value. So starting in 2019, they're definitely going to be looking at other payment arrangements. They're going to be looking at non-Medicare payers. So we know there's lots of groups out there doing shared savings programs through commercial payers. Medicare Advantage is not part of this right now. So, however, in 2019 and beyond, Medicare Advantage is considered an other APM. So that is something that is going to be available as they flush this out and figure out how do they actually start to measure and hold groups accountable to these types of metrics when they're being accountable to other metrics by their commercial payer. So this could, you know, potentially put a lot of pressure, I think, on physician groups to really consolidate metrics as we continue to drive down that path through the MAP process and through NQF. There's still, I think, a lot of opportunity on setting up that criteria when you talk about the other payer, non-Medicare providers or non-payers. So that's where I stand on the APMs. We've got 10 minutes left of the program. So I think we're going to open this up to questions. Oh, actually, I have a quick wrap-up. Thanks, Maria. So before we open up to questions, again, I've spoken a lot about really understanding your macro roadmap. And all organizations are really going to have to sit down and spend some time thinking about this. So they may be submitting their first year as a MIPS provider. However, that movement into the advanced APM is very enticing, adding dollars and making it more palatable for physicians to participate. So we have really important critical points. Again, we're going to a movement of prevention and value. and not just paying for volume. Let's go to the next slide. Here's how Watson right now can support this program. So you can see we have a lot of solutions out there for our providers out there who are part of this program, and we are happy to always talk to you further about how we can help you meet this criteria. Next slide. And of course, so to wrap it up, you know, I think it's important to understand the program, understand your pick your pace, what does that mean for your organization, how you're going to report. Again, it's only Medicare Part B. If you are low volume of patients or low dollars, you will be excluded from the program. If you are going down the advanced APM road, very clearly understand where your organization sits, and CMS will be providing you with a lot of information. Make sure you are signed up for all of the CMS webinars, and you have appropriate staff and personnel to support this program and to understand where you're performing at. The reporting starts January 17, as Maria spoke about, and that first payment adjustment is 2019, just around the corner. So we have 8 minutes left, so I know we may have some questions out there in the chat, so we'll open it up for more questions.
Okay, thank you so much, Jackie and Maria. Before we open the Q&A, I know we are pressed for time, so I want to reiterate to everyone, any question you enter, if we don't answer it today, we will answer electronically back to you, so that's great news. Also, I wanted to re-show the poll results. I don't know that those were clearly shown at the beginning, so for that first question, I'm going to show those results real quick to everyone in the group. You can see, picking your pace, most folks were selecting for a full year. And then for that second question, real quick, most folks are planning to utilize their EHR as their main method to do the reporting, followed by a quality registry and a CMS interface and so forth. So again, just wanted to be sure to share those results there with you guys. So to reiterate, at this time, you are welcome to submit a question at the question panel located on the bottom of your control panel. We'll try to answer as many questions as we can here over the next few minutes. And again, those that aren't answered live, we will get answers back to you. So first and foremost, to our speakers, we have a question that came in that says, for group reporting, if the group is multi-specialty and one of the clinics is a certified medical home, does the entire group get credit?
Maria?
Yeah, hi, this is Maria. So yes. Yes. The answer would be yes, unless, Jackie, you've heard something else.
Right, no, the answer is yes, the whole group, because remember, it rolls up to all MPIs that fall under that tax ID, so there's just no way for them to differentiate who's in the PCMH and who's not. So everything, remember, at a group level totally rolls up to the group. Now, you may have physicians who are, practicing but not in the same tax ID, then they will not be included. And we know of folks who have outside affiliated physicians in their ACO, so they roll up to that tax ID, but they actually don't qualify for some other program. So it's all about the tax ID and the roll up of tax ID.
All right, thank you. Hopefully that answers the question. Again, if you need additional detail to the individual who submitted that question, please forward in those details. Okay, secondly, we have another question coming in. For reporting purposes for quality, do we have to just report or meet targets to get the incentives? I don't know exactly what you're meaning here. Do they have to just report or meet the target / benchmarks to get the incentives?
So just by the means of reporting, if you, there is a slide further up where it kind of breaks it down specifically for quality, but I will say that if you're reporting on the quality piece, as long as you meet that one measure for 90 continuous days, you should get to that 3-point mark, which would give you that neutral payment adjustment. So again, there's caveats to that, and again, I will, you can, like I said, I actually have it laid out. Let's see if I can find it actually, just to provide you a little bit more context to it. So for instance, as you can see here, the quality performance category scoring measures. As you can see, you can, if you meet that specific description, you can receive between 3 to 10 points if you meet those criteria. But in the event, it's possible that you don't have a benchmark for one for that particular measure. You don't have at least those 20 Medicare patient cases, or that measure does not meet that data completeness criteria, then instead of penalizing you for at least trying to report, CMS will give you those 3 points. So I don't know if that answers your question. And again, please let me know if that doesn't answer your question, but I do have it referenced.
You know, another component of this I think that's really important for organizations who have been reporting into PQRS, and because we know over 35% of physicians actually have not reported into PQRS in the past. So this is a huge opportunity in this program for some dollars to be made potentially for those really high-performing organizations and physician groups that can really tap into that $100 million that's out there above and beyond a 4% payment increase. So I think there's dollars at stake that practices could potentially be tapping into, or physicians could be tapping into based on their performance. So again, important components for groups to think about as they really plan out their macro roadmap. What else do we have?
Yeah, and actually just real quick too, and I will mention that CMS is trying to encourage other types of reporting, so not just, not just the typical quality measure reporting that's out there. Everybody's measuring diabetes. We know that's important, but the more unique the measure is, the higher likelihood you can have in terms of scoring. So also encouraging to report on other measures that most people haven't already, if it applies to you, of course, but just putting that out there.
All right, we're going to try to get to at least another one. Thank you, girls. We have, the next question is, we have multiple TINs that make up our APM. If we were to move to an advanced APM, would the 5% bonus be paid out to the APM or directly to each TIN?
Oh, that's a great question. I do not know that, but I would imagine if your advanced APM rolls up to the TIN, it would be paid out at that highest level TIN. But we'll have to double check that. I apologize.
We'll double check that. Yeah, I think my understanding is it would be at the TIN, but I want to make sure that folks on the call also understand that 5% lump sum is at that quality at the QP level, and it's based on an estimated aggregate payment of Medicare Part B covered professional services. So people often wonder what that 5% encompasses. That lump sum payment is based on the QP's estimated aggregate payment. And so I believe we can look that up, but I believe it is at the TIN.
All right. Well, thank you. And we will get some direct responses back to the questions we weren't able to answer here today. We are at the top of the hour. I want to be respectful of everyone's time here involved today. I'd, number one, like to thank our speakers, Jackie and Maria, for their time, as well as for all of the guests who were able to join us. As a reminder, you will receive a follow-up email. It will come within 48 business hours of this session that will have access to the slides as well as recording. And when you go to log off, there will be a very brief survey, a few questions regarding the effectiveness and your opinion of this webinar. So please take the time to share that with us. That way it'll help us improve future webinars for you guys. And as well, we'd like to just at this time in the webinar, and again, thanks for all who attended. Have a wonderful day.